So a pleasant good morning to everyone. Thank you for joining us for this second training session for media workers and health communicators. I'm your moderator for today once again. My name is Lisa Bailey, and I am a consultant working with the PAHO Caribbean office. Today, we're going to be discussing the role of journalists in addressing stigma in the context of COVID-19 with an emphasis on mental health. And we have a wonderful panel lined up for you once again, and everyone's going to introduce themselves, so I'm not going to spend a ton of time on introductions. We're going to start first with our opening, and that will be done by Ms. Kimberly Gittins, and she will be followed by Dr. Claudina Cayetano. Kimberly, I'm going to ask you to begin with the opening remarks. Thank you.
Thank you, Lisa. Dr. Claudina Cayetano, Advisor on Mental Health with PAHO. Ms. Sue Baker, Global Director, Time to Change. Jenny Regan, Mental Health and Media Consultant. Ms. Ashley Baldwin, Specialist, Media and Communications with PAHO. Dr. Alison Leacock, Chairman of the Barbados Broadcasting Authority. Ms. Tamika Garnett of the Guyana Chronicle. Ms. Kimberly Hibbert, Senior Staff Reporter, Jamaica Observer, media representatives, health communicators, journalism students, colleagues, good morning. Thank you for joining us for this webinar on the role of journalists in addressing stigma and discrimination in the context of COVID-19 and mental health. We at the Caribbean Development Bank are pleased to partner with PAHO and the Caribbean Broadcasting Union to deliver this training. This training is actually the second in a series of 4 on responsible reporting on COVID-19 for journalists and health communicators in the region. As we speak and as we meet, there are about 60,000 persons in the Caribbean who have tested positive for coronavirus. 9,000 or so of these persons actually reside in countries that are born members of the Caribbean Development Bank. As we know, this health crisis brings challenges such as reduction in economic activity, there's strain on businesses, rising unemployment, loss of income. Many of us are also familiar as parents with disruptions to education and the requirement for social distancing and isolation. The effects on mental health and emotional well-being are well documented, and these include fear, depression, and anxiety. Given the small size of Caribbean societies, those of us who have not been significantly impacted in a direct way are likely connected to someone who has been or will be. Unfortunately, there remains a troublesome nexus between infectious diseases and stigma. We all know that stigma serves only as a significant barrier to seeking health care, and it adversely affects individual health outcomes and related life chances. There are multiple media reports and personal testimonies of social stigma and discriminatory behaviors against persons who are perceived to have been in contact with the coronavirus. And the same applies for persons who are living with mental health conditions. Stigma is fueled by a number of factors, and these include fear and a lack of credible information, which brings us to this forum. The role of the media in providing quality and timely information is absolutely critical in tackling stigma. Today's webinar will provide participants with specific tips, tools, and recommendations on how to address stigma and discrimination during the pandemic. You will also hear of a number of global campaigns that have successfully addressed these key issues. Finally, we have a group of experienced Caribbean journalists who will share examples of good practice in reporting on COVID-19, on mental health, and other diseases, as well as health conditions. The feedback on the first webinar really validated the need for forums such as these. And we've heard from some participants of the value added professionally and personally. We hope that today's session is no different. We invite you to listen closely, to raise questions, and also to share examples from your work in the field as we continue to work together to support resilience in our societies. Thank you.
Thank you so much, Ms. Gittins, and we are very happy to be here with you. If you're just joining us, thank you for being a part of this second session. I'm now going to ask Dr. Claudina Cayetano. She's the mental health non-communicable and mental health from the mental health department at the Pan American Health Organization to bring a few opening remarks. Dr. Cayetano?
Good morning. Thank you very much, Lisa, for this opportunity. I was not the one to be speaking to you this morning. I'm speaking on behalf of my colleague, Elisa Prieto. Elisa Prieto, NCD and non-communicable disease sub-regional advisory. She is at the Office of the Sub-Regional Program Coordination for the Caribbean and stationed in Barbados. Some of you who have had the opportunity and the pleasure to work with Elisa know that she's committed and determined, and actually we're having these webinars because of her determination. So I am very, very pleased to represent such a person like herself. My name is Claudina Cayetano, and I'm the advisor for mental health. My background is a psychiatrist, and I'm stationed at the office in headquarters in Washington. Having Mrs. Kimberly Gittins, from the social analyst from the Caribbean Development Bank, I think she had already established protocol. Nevertheless, I want to welcome you to this fabulous training. I'm so excited to see the lineup that we have from Time to Change to from the fields or colleagues from the Caribbean that will be participating. I'm also very grateful to have our colleague from PAHO office and the support that we've been receiving from Ashley Baldwin, Ms. Baldwin, and from Mr. David. I'm very grateful for the opportunity. As you know, in the Caribbean, mental health and psychosocial dimension of this COVID pandemic include risk of increased, domestic violence, stigma, discrimination, and this becomes even much more relevant when we're talking about this is for us in the Caribbean, it's a hurricane season, which officially runs from June to November. So the role of the media becomes much more than now relevant, because it is very important that people are receiving timely and accurate, frequent information in a language that people understand, via channels that enables them to make informed decision and adopt positive behavior to protect themselves and the loved one. And when it comes to mental health, as you all know, in the Caribbean, there's a huge stigma discrimination. So the role of the media becomes much more definitely relevant. I know you're going to help us to be able to make a difference, and this is why we're having this webinar. So welcome everyone, and thanks for taking time to be with us. Back to you.
Thank you so much. Thank you, Dr. Cayetano. So we're going to get straight into this. Just a couple of things to say. If you're going to ask a question and you want to have an audio question, you want to say or speak or turn on your camera, this is intended to be an informal training experience where we're learning from each other. So please feel free to do that. However, if you cannot speak, you can type your questions in the Q&A box. There is a Q&A box provided for you, and we'll be keeping an eye on that. There's also the chat box if you just wanted to say hello, where you're from, because we have people from all over the Caribbean from before. So we're hoping that will be the same this time. So we're going to move straight into framing the discussion, and we're going to be starting with the experience from the Time to Change program. I'm going to call on Sue Baker and her colleague Jenny Reagan to bring the first discussion point for us. Thank you.
Thank you very much. And good morning from Jenny and I. I'm going to start sharing the slides in a minute, but just a bit of an introduction to who we are. We're based in the UK. We run the Time to Change campaign, which has been running in England for 13 years to shift attitudes and behaviours, faced negative attitudes and behaviours that we have when we experience mental health problems in the UK, but we have seen a sea change in public behaviour and attitudes. And that's one of the most evidenced series of change in stigma and discrimination in the world. We now happen to be working with amazing charities in East and West Africa and India, and we work with global colleagues on stigma and discrimination, but not yet PAHO and not yet in the Caribbean. So we're really, really delighted to be here to share some of our learning. This is only specific to England, but there is a lot that can be shared and adapted, as we're finding in Africa and India. Sadly, stigma and discrimination is a global problem. Very few societies don't stigmatize, discriminate, exclude, and abuse people with mental health problems in communities. So we're going to share some of the learning about working with the media. Jenny is a real expert and an ex-BBC producer. We both have our lived experience of mental health problems. We as a society, all of our societies need to be far more open about the fact that many of us have lived experience. Anyway, without further ado, I'm going to start to share our slides. We'll take the questions as we go through, I think, and Lisa's going to help us with that, hopefully. So let me just share my screen. If there's any kind of nuances that are particularly sort of specific to our context and aren't coming through, please let us know, and we will find a different way to articulate them. So how have we gone about this in England? As I say, we're 13 years in England with one of the biggest, most evidence-based campaigns in the world, but lots of examples to share. Now, we're not going to focus too much on the background. Our media coverage of mental health has been abysmal. Most of the coverage, and this is back about sort of 10 years ago, if not longer, was all about violence, killings in the community, and terrible language, like you can see. And one of the worst examples, I don't know if you know Frank Bruno, who's one of our most famous boxers. He's a national hero, and our biggest selling tabloid newspaper decided to release the fact that he'd just been detained under our Mental Health Act, and they called it Bonkers Bruno. And there was a massive outcry. This is the first time in our country we'd seen such an outcry from readers, from mental health campaigners, from fans, from sports people. And that was the first edition that you can see over there that came out overnight and in the morning. And then literally there was such an outcry that this was the second edition, where it's much more empathetic. And then the newspaper didn't just apologise, it also made donations to mental health charities as well. We've come a long way since then, but that's all the kind of coverage. That was the norm, to see mental health, specifically severe mental health problems like bipolar, schizophrenia, other types of psychosis talked about. So I'm going to hand over to Jenny now about why the media is so important, what people in our networks of people with lived experience of mental health problems tell us about stigma, and why it's helpful.
So when we started to look at the media, we asked all our supporters what they thought about the media, and 80% of the time said that the portrayal of mental health problems, and that's across newspapers, televisions, all the kind of mediums, were poor. And a lot of them actually said they've been kind of personally affected by seeing things in the media. So it actually kind of found that the stigma had increased for them by seeing something that they'd written, that had been written or kind of shown. However, on the plus side, we also realised that people could actually kind of gain help and find that they could kind of understand how different illnesses kind of basically find people that had the illness too, so understanding of the issues. So we realised that actually, although at the time the media was pretty stigmatising towards those of us with mental health problems, we also knew that there could kind of be a much kind of bigger thing we could do to kind of harness this. Next slide.
I'm just trying to, it doesn't seem to be allowing me to go through it. Hang on a sec. No, we've gone far too, yeah, here we go. That's just a quote.
This is something that this is kind of very typical of what one of our supporters at the time said, that they were very reluctant to actually go and see a doctor, because at the time you often saw in coverage of mental illness that it was all around the kind of mad and dangerous. So this person actually said that they hadn't sought help because they were concerned about kind of being seen as they say, as a lunatic. Now, one of the most important things we realised we needed to tackle was reporting suicide. And at the time, again, what we were seeing was coverage that was far too much detail about method. What we also saw was people oversimplifying the reasons of suicide. This is a really good example. Robin Williams, and all the headlines around him kind of revealed how he had taken his own life and really kind of tried to guess why. We know that when the method involves something quite unusual, that it can really, really have a knock-on effect. And we know there's lots of studies done that says that people who are vulnerable may copycat the behaviour. And we know that again, whether it be newspaper coverage, it can really affect people. So what we ask reporters in the UK to do is to focus on feelings, not behaviours. Again, don't be explicit about methods. One of the main things here is also not being specific about explicit about places, so-called suicide hotspots. We know, again, in the UK, that there are certain places people associate with suicide, and once it's reported in a newspaper or you report where someone has taken their own life, you always tend to see a spike in suicides in that area. One of the main things we ask is that you don't oversimplify and you don't kind of guess why people have taken their own lives, and also presenting the behaviour as the kind of appropriate solution to the problem. So if somebody gets what they want from taking their own lives, it can be really troublesome.
I think it's also really important, obviously all of our legislation and legal frameworks are different, but we talk about people dying by their own hands or people taking their lives. We don't talk about, we don't put it in the legal frame which only adds to the stigma. If you talk about people committing suicide because they've committed an act, obviously that depends on your legal framework around that. I think we're just going to need to move on.
Sorry. So what we decided to focus on, we wanted very much it to be a peer-to-peer approach. So I have a background in the media. I was in the media for a number of years. So basically it wanted to be an approach where we're talking with people rather than to people. So we set up an advisory board made up of people with lived experience and people working in the media to really help shape the service and advise on what we needed. And we realised, as well as newspapers, who were the kind of main culprits, we needed to do a lot more work with drama and documentaries. But again, the approach was very much working with rather than kind of telling people off. So the first thing we did was bring in a day-to-day advisory service. This meant that journalists or programme makers could come to us if they had any questions, not just about what mental health conditions were, but also about how to report or how to kind of present. The second thing was training and outreach, and this again really kind of brought in our lived experience volunteers. We make sure that every time we do a workshop with a group of journalists or with a drama, that we always have somebody with lived experience to kind of guide us through that. And the third thing is the media awards. And again, we found that rather than just telling people off and telling people what not to do, that actually giving some people a reason to produce very good mental health coverage was a far better way of doing it. So the media awards have been running through the charity Mind for a number of years now, and they really celebrate positive mental health. And it went from people in a room, about 100 people, and really having to kind of struggle to find good examples, to 2 years ago, holding an event with Prince Harry presenting an award, 1,000 people in the room, millions of people seeing it on kind of across the media, and just really goes to show in the last few years how much better mental health coverage has got, which is a really bonus. So looking at some tips, again, these are very much for the UK, and it's difficult to kind of know what your issues are in different countries. But what we look at is if you are reporting on mental health, just check, is it relevant to the story that the person has a mental illness? We often see headlines which call people by their illness. So, person with schizophrenic, for example, robs a store. However, there's nothing about his illness in there that actually is necessary. Don't speculate. We often see people kind of diagnosing by media. So they will sit there, particularly when there's a terror attack or a big event, and you'll see people who are neighbours or who are doctors kind of trying to label that person with a diagnosis. And we've seen that quite a lot, particularly when sadly the perpetrators have died in many ways. It's really unhelpful, and it also kind of perpetuates the stigma. Thinking about headlines, there can be some really fantastic stories, but then the headlines kind of ruin them. So we've seen that quite a lot. And also check your sources. Do you rely on neighbours? Do you rely on experts? If you can do, please bring in people with lived experience to your work. And just generally, again, when you're kind of looking at mental health, the main thing we look at is really trying to bring people with experience into the conversation. So recovery is always a really good story to cover, inspirational stories, sympathetic representations, real life experiences. We love to kind of share experiences. I think it really opens up to other people. Causes of mental health problems, and also kind of discussions of stigma. So the story shouldn't always need to be about the bad side of kind of mental health, although, you know, in this country particularly there's a lot of bad sides in terms of how I think people are treated, but I think it's also kind of a chance to open up the conversation further.
I think it's also really important to note that from all of our evidence in the UK and now in East and West Africa and Southern India, the most successful evidence-based approach to addressing stigma is hearing from people with the direct experience and putting photos and a whole perspective of somebody's life. You know, I'm not just somebody with depression and anxiety, I'm a fuller, richer person. And actually, if all you ever hear is about someone's mental health problem, you've just got a very, very one single perspective on their lives. So, you know, talk about much wider than that person's mental health issue. And that absolutely does, your viewers, your readers will appreciate, you know, more real human interest, and that will help on the stigma front as well. I'm just conscious of time, so we're going to have to flick.
Yeah. So another thing we do is very much working with dramas. We found that a really kind of successful way of tackling. And I'm going to pass back to Sue now to talk about the results we've had.
Thank you. Just on the dramas, I mean, Jenny's being very, very modest. She works on 84 scripts and storylines a year at Mind, and that's the charity we both work for in England and Wales. So that's EastEnders, Coronation Street. They've all had these reach millions of people for a tiny amount of budget, with responsible, empathetic, insightful, entertaining storylines. I remember 20 years ago somebody said to me, I covered mental health last year. And I thought, last year? It affects a quarter of the population. So all the major soaps now have major stories of their characters who live every day with mental health problems, who happen to be fathers, workers, mothers, doctors, and she's done an amazing job. Now, if you can get storylines like that, which show the bigger picture and don't demonize and stigmatize, that could be a very successful approach, and get the charities and people with lived experience to help you. So that strategy, it's all about having people with lived experience who are trained, supported, lots of safeguarding needed, make sure people can choose what they decide to share with the media, and that does mean standing side by side and supporting and training people. So, for example, in the global program in Africa and India, we've now got 111 people who are bravely sharing their stories, unlike the vast majority of the population, who we support and our partners support every day of the year to do that. And that's one of the most successful approaches, as I keep banging on about. And why I say successful is because we have lots of academic level evaluation. It shows that print media coverage in the UK, this is big regional papers and national papers. A sample were evaluated from 2008 to 2016. I'll paraphrase what you can see here in this slide, but basically it used to be stigmatizing articles, non-stigmatizing at the start of our program in 2008. Then it kind of evened up, and now it's gone like that. So there are far more destigmatizing pieces of coverage than there are stigmatizing. And people haven't lost viewers and they haven't lost readers, which was another fear. One thing that we were going to share, but I don't know if we've got time for, is the importance of images and having more sort of positive images. So we're going to just have a couple more minutes, if that's okay, just do's and don'ts, but we can leave these slides with you. Jenny's kindly done these. So we talked a bit about the language not to use, but it's no use just saying don't use this and don't use that. You have to say try using this instead. So, you know, like we say, it's not a stick to beat the media with, it's a carrot to say let's work together and find some solutions. Let's give you people to interview. You can share a different side of the story. You can talk about recovery. You can talk about all the other aspects of life. These are the resources that we have on the Time to Change website. We're not going to show any of the films, but if we get a chance, I'll pop in the chat a link to some of the training films. They feature journalists training other journalists, whether they're news, sport, crime, dramas, documentaries. So there's a whole load of films. Obviously, they're only in our context, but they might be of interest. And that was it. I was just going to talk to you about the global work, but I won't. I only run out of time.
Thank you very much, Sue and Jenny. That was very interesting. And I see we do have a question, a hand raised, and we have two questions in the Q&A. And I wonder if we should go to them or if we should go straight to Ashley. Ashley, do you mind if we take these now? Because I think maybe
Absolutely not. No, let's carry on with the momentum.
Okay.
If you agree.
Yeah. Sure, that's fine. So we're going to do the question, or you want to go?
Do you want us to respond to?
So,
Ashley, can we do the questions and then come to you?
Oh yes, of course, of course.
Okay. So John Guerra Sansonetti, I'm going to allow you to talk now if you'd like to ask a question directly to Jenny or Sue. Please feel free to go ahead, and then I'll give you the two from in the chat box. John, you can unmute. Okay, I'm not going to spend a lot of time, but if you can unmute, I'll go to the questions in the box. There's a question here about fear. Is fear rather than stigma of COVID spreading good? At least fear makes people take the necessary precautions and measures. What do we say about this? Is fear rather than stigma good?
I mean, I've heard that debate just from our perspective, debate before, and absolutely giving people information so that they take action around particular public health issues is really important, but not to fuel myths and not to perpetuate existing stigmas and limited understanding. Yes, provide the facts, give people the information so they can take action, but then don't discriminate and isolate people who then experience that health issue. So there's a difference between providing knowledge and information, but fueling fear so that people then discriminate and isolate. I think that's what you've got to be careful of. I mean, in mental health, why would you fuel any fear? You don't want to stop people getting help, and stigmatizing something stops people getting help or taking action. So it's just my immediate perspective on that.
I guess also, I mean, in many ways, yeah, you would think that you do need, particularly in the UK, we've seen, you need a level of fear really to get people to behave in a certain way. However, we possibly could be living with COVID for years, and when does the fear then kind of feed into the stigma of people who experience it long term or experience it in the future? So yeah, I think there's an element of it could be a good thing, but yeah, it's short lived.
Yeah, and I think fear can then lead to depression and anxiety. So I would say fear probably not a good thing either. That's just my non-technical thinking on it. Just to say, someone is saying, please share the images.
On the fear?
Sure, Allison? Go ahead. Was that you, Allison? Yes, go ahead.
That I agree with both HIV experience. It has proven that fear doesn't change behavior. So it's not really a good thing in that context.
Okay, I think we can move on now. We do have someone saying in the Q&A box, please share those images. So time to change, please feel free to share some of those examples in the chat box, because people are very interested to see some of the imagery. I'm going to throw now to Ashley. She's a specialist in media and communication in the Public Affairs and Communications Department at PAHO headquarters, and she's going to be talking to us about the key recommendations to prevent and address social stigma associated with COVID-19. Ashley, over to you.
Thank you, Lisa. Hello, everyone. This is the second time that you're seeing me on one of these webinars, and I'm sure it won't be the last. So it's great to see so many of you that were connected to the first webinar reconnecting for the second one to have this important conversation. So as Sue and Jenny mentioned, there was a lot of discussion about stigma in the context of mental health. And what I want to talk a little bit about is, on the one hand, how does that relate to reporting on the COVID-19 pandemic? And on the other hand, what are the practical things that journalists can do to make sure that that isn't perpetuated in our reporting work? So I'm going to share my screen with you now. Just bear with me a second. Okay, so my presentation is going to be based on a guide that was developed by WHO in collaboration with UNICEF and the International Red Cross. It's available on the link to the right if my screen hasn't been mirrored, but we can also put it in the comments section as well. And I would highly recommend that everyone access this guide. It's 4 or 5 pages long, it's super short. It's very practical and it's very action focused. So I'm just going to go through some of the main principles of the guide very quickly, and then we can get to the juicy bits, to the questions at the end. So within the context of the COVID-19 pandemic, we're seeing primarily, although not exclusively, 3 types of stigma that are repeated over and over again in the media. The first is stigma related to nationality in the context of the COVID-19 pandemic, predominantly directed towards people that are from Wuhan, people of East Asian descent. The second is we're seeing stigma, particularly in some countries, against healthcare workers. So people who are confronted with the disease, working very closely with the disease every day, and are therefore sort of being misperceived as carriers of the virus and sort of perpetuating the pandemic. And then thirdly, and this is something relatively new within the context of the COVID-19 pandemic, as lockdown and public health measures continue, and we're seeing an increase in certain mental health issues that are related to that. You know, we have parents who are juggling full-time jobs, teleworking, raising children, managing the education of children. We're also seeing people who are isolated from friends and family because of physical distancing measures, etc., etc. We're seeing the manifestations of mental health issues from that sometimes negatively portrayed in the media in certain countries. So what is the impact? So stigma can drive people to hide COVID-19 in order to avoid discrimination. So we want people who are experiencing symptoms of COVID-19 to seek the care that they need from healthcare facilities. Stigma prevents people from seeking that care immediately, which of course has negative implications when it comes to spread. And stigma also discourages people from adopting healthy behavior in order to manage not just the pandemic, not just COVID-19, but some of the public health measures around the pandemic. What we know is that the media plays a tremendous role in influencing public behavior, and particularly when it comes to public health and when it comes to enforcing the public health measures that have been recommended by international health organizations such as WHO, such as CDC in the United States, and also from ministries of health at a government country level. So we know that certain words, for example, isolation, suspect case, may have a negative meaning for some and can fuel stigmatization. And this is because referring to a case, for example, is dehumanizing language to use. It separates the human aspect from the person. So this can really drive people away from getting screened, tested, and quarantined, which we know are the only ways to stop the spread of COVID-19. So what we need is to collaborate together with journalists, with media outlets, to ensure that we use people-first language that respects and empowers. So some of the tips that are outlined in the guide and that we recommend is that journalists must talk about COVID-19. The solution isn't to ignore the elephant in the room. This is a very real issue that's affecting us all in a myriad of ways, and it needs to be discussed. But when we talk about COVID-19, let's talk about people who have COVID-19, people who are being treated for COVID-19, or people who have recovered from COVID-19. Let's not talk about cases, victims, etc. Much in the same way that Sue and Jenny were discussing about, attributing a mental health issue to a person. Someone with a particular mental health condition should not be referred to in the media as a schizophrenic. And it's the same for other conditions, including COVID-19. So we need to talk about people acquiring or contracting COVID-19 rather than place the blame and the onus of spread on people who spread the disease, people who give people COVID-19. You know, this isn't an intentional action. You know, people aren't going around sort of infecting other people. This is, you know, millions of people have this and it's acquired or contracted. We need to ensure that reporting is based on fact. So we need to speak accurately about the risk. It needs to be based on scientific data and latest official health advice. And this was really tied into the question earlier on about fear. So we can really tackle fear if we talk about things in scientific terms based on the available data. Now, the available data can be accessed very easily from the PAHO website. It can be accessed very easily from Ministry of Health websites. All of the information that journalists and the general public need is there. We need to also talk positively and emphasize the effectiveness of prevention and treatment measures rather than focus on that fear, which we know is linked to stigma. There are certain measures that people can do, the physical distancing measures, lockdown in some contexts, wearing masks in some contexts, hand hygiene, sneeze and cough hygiene, that we know will help control the spread of COVID-19. So we need to adopt that role as journalists and reporters in promoting those public health measures. And we also need to emphasize their effectiveness. So the reason why some countries have been able to flatten the curve, why some areas have been able to flatten the curve, there really is a direct scientific link between the adoption of these public health measures and the reduction in cases. So what should we not do? We certainly shouldn't attach locations or ethnicity to COVID-19. Now this applies to the origins of the disease as much as it applies to certain countries or certain areas that are experiencing outbreaks or spikes in cases at the moment. We need to avoid referring to people with the disease as cases or victims, as I mentioned earlier. These are people with COVID-19, people being treated with COVID-19. We need to avoid talking about people transmitting the disease or infecting the disease, because that again places blame, which leads to stigma. We need to avoid sharing unconfirmed rumors. Now there is a specifically dedicated website from WHO where you can go and check the myths around COVID-19. So there are many resources that are easily accessible in multiple languages for reporters to be able to verify the information. And if you can't verify the information and that particular resource doesn't exist, talk to the Ministry of Health, drop their communications team a line, drop the PAHO communications team a line. We're constantly responding to inquiries along those lines. We need to avoid language that generates fear, like plague or apocalypse, and we need to avoid dwelling on the negative. So by working together, we will help keep people safe, and these are the measures that need to be done in order to flatten the curve and stop the spread of COVID-19. So the role of journalists is a very important one when it comes to ensuring public health in the context of the pandemic. In the context of the pandemic and also in the context of ensuring that people maintain their mental health as well during the public health measures that are being recommended by governments and international organizations. So there's just a few, 6 simple tools that reporters should do. The first is to focus on facts, always focus on facts. The second is to engage social media influencers, ensure that these voices of authority are amplified. So for example, with WHO, we collaborated with Lady Gaga at PAHO. We're also collaborating with other celebrities, with popular television programs like Sesame Street, etc., etc. So all of these sorts of things will help to enforce that positive message and reduce the stigma around COVID-19 and the lockdown issues that are arising from COVID-19. The third, again, as Sue and Jenny mentioned, is to amplify real stories. You know, that's a fantastic way that we can ensure that accurate voices are represented in our reporting. Talk to people who have had COVID-19, who have recovered from COVID-19, share those stories. We need to make sure that we're portraying different ethnic groups in our reporting. So we shouldn't focus on one particular group or on the group that we belong to. Even this is a disease that is affecting everyone, everywhere in the world, all nationalities, and that needs to be reflected so that we don't perpetuate that negative stereotype. We need to follow ethical journalism guidelines, which are freely available and which all reporters sign up for when we go to journalism school. And we need to work together and collaborate and share experiences, which is why the next presentation after the Q&A session that you're going to hear are probably some of the most important, which are examples of journalists on the ground working on COVID-19 reporting and sharing their experiences with each other. Thank you very much, and I will leave the link in the comments section so that you can all access those resources. Thank you, Lisa.
Thank you very much, Ashley. There is already some questions in the chat box. I'll go to the first one. Apologies if this was already addressed. I don't think it was. What advice do you have to deal with the negative information about either what WHO, PAHO advises or against vaccines? So how do you handle negative information? So I think the person is trying to ask, you know, there's a pushback on some of the advice that we give. How do we handle that as journalists?
Yeah, I mean, I think that there's two things. I think the first challenge, which was something that we discussed in the previous webinar that reporters are having to face, and that everyone's having to face really, you know, including us here at PAHO, is the fact that COVID-19 is a new disease. And we're constantly finding out new information about it. And therefore, advice is changing depending on that new scientific information. So that's a challenge, not just for public health workers, not just for international organizations and governments, but that's also a challenge for journalists. You know, one week we're saying, actually, you know, mask use isn't strictly necessary. We continue to analyze the evidence and then we find that actually it is, and that's a new recommendation. And that's definitely a challenge when it comes to how can we maintain trust in media outlets in a context of changing information. The second, when it comes to sort of negative information, is just to ensure, again, that everything that we're reporting on is based on scientific fact. And it is available on WHO's website, on PAHO's website, on Ministries of Health website. So we just need to ensure that everything is data-driven when it comes to COVID-19 pandemic. I hope that answered your question.
Yes, and I think we always say in all of these trainings, the information changes all the time. This is a new disease. So, as we learn, we update the guidelines. There's another question for you, Ms. Baldwin. Caribbean states are close-knit communities and everyone knows each other. Although we highlight the cases and the recoveries anonymously, a number of people still know who the people were that have contracted COVID-19. How would you respond to this, as people who recovered would still have some discomfort coming out of isolation? And you'll actually hear about this from, I believe it's our Guyana presentation as well. But Ashley, if you wanted to respond to that.
Yeah, I mean, I think this is, you know, as someone who's based in Washington, as a British woman who's based in Washington, D.C., I think I'm definitely going to defer to my Caribbean colleagues when it comes to this one. But I think that just highlights, you know, the fact that there are many Caribbean communities where, you know, for want of a better way of saying it, everyone knows each other. And of course, that has implications when it comes to stigma regarding COVID-19, stigma regarding mental health. That's why it's so important that Caribbean journalists really take the lead in addressing these issues and ensure that we have accurate reporting that challenges that discrimination as well as avoids it.
Can I go, Lisa? Do you mind?
Sure, go ahead. And Tamika wants to say something after, so go ahead.
Okay, thank you. I will try to be brief with this, but I think definitely the Caribbean journalists, this is a fantastic opportunity to be able to change that culture. I think I mentioned that at the beginning. My work, my clinical work, I know firsthand the impact of discrimination on people's life. People suffer in silence. We know about the high rate of suicide that happens because people just don't want to seek help. And I enjoy the fact that we know the journalists the work that they can bring to do responsible reporting. So it's not about pushing people to become, if they're not comfortable to come, because suffering COVID is very painful. It's very, very painful. So at the same time, we want to be able to bring that, the importance of that to people in a way that what we want is to have more responsible reporting. So it's not that, so in the Caribbean, because you want to use that as an opportunity to encourage people to seek help. I think that's the message that I want us to get here. It's not to be ashamed, it's to make put the suffering out there, the importance of why we need to be, empathic to people when they have been infected by COVID. I think that's the message that I would like. And media can do that very well, definitely. Thank you.
Thank you, Claudina. Tamika, you wanted to say something?
Yeah. I had a question for Kimberly. When she was during her presentation just now, she mentioned not disclosing locations. So what I wanted to ask is not adding the locations where persons were tested positive for COVID-19. Wouldn't knowing the hotspots be important to persons, or knowing spots where cases are discovered be important to persons in those areas so that they know that they're at an increased risk if they live in that area, or they could have even possibly come into contact with the person that tested positive? Because early on in Ghana, we know we had the health authorities weren't disclosing locations, and then eventually they started to disclose the locations, because what they found that those particular locations where they found the initial cases, they started to find an increase in cases, and they were like thinking perhaps it's because persons weren't taking enough precautions in those areas. And then when they started to disclose the area now, persons I think may have been a bit more cautious if they're going into those type of areas. So is it important for persons to know locations where the COVID-19 cases are coming out from?
Sounds like a delicate balance there. Did you want Sue, Jenny, or Ashley to address that one? Or anyone else? I think this is a discussion at this point, so go right ahead.
Yeah, there's a really interesting tool. We train people to share their lived experience. And obviously, as I said, you've got to think about safeguarding. The individual that's going to share their story has to consider the risks. You have to work through people what the implications are. As one of our colleagues attending has said, if you live in a small community, but, we've worked in very small rural communities all across England, from Cornwall to up near Scotland, in remote southern India, in villages where some of our people speaking out have never left their village, and they're willing to share their story. And the same in East and West Africa, where stigma of mental health is everywhere. We all unfortunately share that experience too, as well as COVID-19. But the one thing that we do when we're training people with lived experience is just one simple tool to share. I'm not suggesting people on this call do it, but to give people back the power about how much of their story they share. We have a sheet of paper and we draw a line across the middle, and we say, put above it what you'd like you'd be happy for other people to know about, your neighbours to know, your employer to know. You can't control who's going to see that information. Once it's out there, especially in the digital world, it's out there. And then put a line there and put underneath what you're not comfortable for everybody to know about, that you don't have control about. Once you've said it, you've said it. And then what you encourage people to do, and what we do in our program, is constantly review that. So that obviously if you said it once, it's hard to then retract it. But there might be times in your life when when you're looking for a job and you're no longer willing to say those things. And the same should be the case for people experiencing COVID-19. Only share the bits of your story you're willing to share right now, and then keep that under review. But you have to support people, because people's jobs are at risk, their relationships are at risk. as some of our fellow panelists were saying, you know, the discrimination is incredibly hurtful. It's nasty words. It massively impacts on people's livelihoods, relationships, ability to you know, get on with life. So I think supporting people who are going to share their stories, to consider the implications before they do, and then to keep considering it, but to have control over how much they do share, I think is a really important part of this equation. Jenny, do you have something to add to that?
Okay, she says she's fine.
Sorry, I was muted. Not really. No, I think you've said it all there. So I think it's, you know, it's giving the people with the expertise the option. I guess in terms of location with COVID, it's slightly different because it might be playing a role in kind of in finding where there are hotspots. But yeah, I don't kind of know the answer in terms of when you're looking at COVID. I don't know if Ashley has a better.
Yeah, I mean, I 100% agree with Sue. We need to make sure as reporters that we're respecting the person whose information we're sharing's boundaries and how much they want to share. And we also need to sort of look at roles as well as reporters. And when it comes to contact tracing, etc., that's the Ministry of Health's job. And the location should certainly not be attributed to the individual story if that person does not want his or her location attributed to them. That's not going to cause a public health issue, because either way, the Ministry of Health is going to be following the recommendations, which are, you know, isolation, contact tracing, quarantine. And that's not something that we as reporters necessarily need to be concerned about as much as we need to be concerned about perpetuating stigma.
Just to add, I totally agree with Sue and Ashley. And I believe the reality is that this behavior and this tendency to want to locate it often fuels more stigma. That's what we experienced in the HIV scenarios in our small societies. So the desire to know the location is not predicated on securing the safety of others, because as Ashley said, that's what the ministry is going to do with contact tracing. They will know how to ramp up messaging to help people in those communities to protect themselves appropriately. But I think, unfortunately, identifying locations just cements the stigma and discrimination for that area, which isn't at all.
Thank you very much. I'm going to take one more question before we move on. I see a question here in terms of, in questioning medical and government officials, how do we get them to tell the truth so as to properly inform the public of what's really going on? That's a tough one.
That is a very tough one. So I'll have a first stab. You know, I think that there's a lot of publicly available information. You know, countries have signed up to international health regulations. When it comes to COVID-19, countries have to report cases and suspected cases. And all of that information is available publicly, both on Ministry of Health websites and also on PAHO and WHO websites. So, you know, if anyone is at all concerned about, you know, numbers being reported, et cetera, then that's definitely a resource that that can be easily accessed by people. You know, of course, governments are going to have certain priority areas that they're focusing on, certain treatments or ways of tackling the COVID-19 that they're going to be focusing on. And it's, you know, as journalists, we're well within our rights to ask questions about that and to find out more information about that. But I think it's just about, you know, using the multitude of resources that we have at our disposal, Ministry of Health and International Health Organization resources. And from that, I think that, you know, we can generally paint a pretty good picture about what's going on.
Thank you, Ashley. I'm sorry, I missed a question from Dr. Virginia Asin-Usberg. Would you like to ask your question now, please? You have to unmute and you can go
Yes,
ahead.
I did. Can you hear me?
Yes, we can.
Thank you. I missed the beginning of the presentation, but I think I got most of the presentation of Ms. Baldwin. I have one comment on the first question that was asked about the location, and I have to say I'm not a reporter. So for me, it's always a balancing act. I'm a public health person, and the question on location, the pressure that has been put on the media is that people in the community do pressure the media to publish not the location of an individual person, but to publish the hotspots. So the pressure from the people to the media to pressure the Ministry of Health is to provide the hotspots so that people themselves can protect themselves. There was a whole discussion on using an app so you will be able to follow or see if someone with COVID would be in your vicinity or whatnot. That has been discouraged, so the app wasn't used here in Suriname. I'm from Suriname, but there is a constant pressure. So the question is always asked on to public health person, what do you advise? So we have advised as public health advisors that not individual information, but that it is important that people know where the hotspots are, because individual person do have their own responsibility to protect themselves. So that's the reflection, and I would really like to know what you think about that thought process and that advice that we had given to the government here. And then there is a second question which is linked to that sharing individual information, and that started yesterday. We have on the COVID-19 website in Suriname several categories that they present: the number of persons positive, active cases, persons who died, and whatnot. Yesterday they introduced a new category, and that is lost to follow up. So from that time on, there is now a huge pressure again from persons from the public to the media to pressure government to publish the names. Because if there is a loss to follow up, where are they? People want to know. There is a scare. People are very, very scared. So I heard also some things mentioned about the way the information should be shared. But still, for layperson, this is a scary disease. So people are very scared, and the majority of the persons want to protect themselves. So how do you deal with that? If you publish loss to follow up, how do you expect the media to handle this so that they can provide that information to the general public? How they can use this information and still protect themselves? Thank you. I'm very eager to hear your reflections on that.
Shall I jump in? So I'm not, you'll have to excuse my ignorance when it comes to the particular case of COVID-19 in Suriname. And unfortunately, we don't have our technical colleagues on the call, on the webinar today, who would normally be following up with that. But that's definitely something that we can answer after this webinar. If you have remaining questions, I can send them to me and I'll pop them in front of our relevant technical specialist. But just to reiterate, I think that there's two things that were brought up in your point. And the first is, we need to be careful as reporters not to perpetuate fear, and to trust that authorities are following the advice of international health organizations, which is, isolation, contact tracing, and quarantine. I don't think that we should be sort of taking it onto ourselves as reporters to be doing that job for ministries necessarily. And the second thing, when it comes to publishing individual information, I don't see it as useful from a public health point of view, so long as governments are reporting on certain hotspots. I don't think we need to sort of name and shame or expose someone who has a particular disease who doesn't want to be exposed. I don't see what public health benefit that would provide. And I think that there's tremendous risk of perpetuating stigma as a result of providing that information. And also, we're going to sort of perpetuate the situation where people shut down and they don't want to admit that, they're experiencing symptoms of COVID-19 or any other health condition. And then they don't seek the relevant treatment for that. And then, it's other people pick up the disease, and we sort of end up in this negative cycle where actually exposing someone is hugely counterproductive, because it's going to make me not want to seek treatment as a result. I don't know if any of my colleagues have anything to add.
Yes, I want to add to that, Ashley. And one of the things that we are seeing that is happening in many countries, this when we're looking at reduced stigma to stigma and discrimination in anything, mental health, domestic violence, people with lived experience is the best way to go for. So this is what we're learning from our colleagues, from Sue and from Jenny. Lived experience. So you bring these people that, and we're talking about whether it's schizophrenia, whether it's bipolar disorder, any of the mental illness, any of the issues that, get people uncomfortable to talk about when it comes to mental health. People with lived experience. So let's keep that in mind, that if we want to reduce stigma, this is what we want to be able to promote. And clearly, people listen to the guidance of reporters. People are listening to you. I mean, we value the information you're bringing. And so because of that, I think we have to keep that in mind. So having said that, of course, and I really liked when we were saying, I think it was Jenny that talked about, don't speculate. So you go to the Ministry of Health. The Ministry of Health also have the reporters that are providing information. Because of the work that we're doing in the Caribbean, one of the things that we are learning is that when it comes to healthcare providers, this big thing about heroes. Do you know that they're doing it in the Caribbean? A lot of the Caribbean islands are celebrating first responders, like healthcare providers, as heroes. And they're doing it in a very positive light. And the media is doing that. So if we could do that in that arena, it's the same thing we want to be able to do for people who have been, because if they have been diagnosed, if they are being treated, what we want is to take that opportunity in supporting them. How do you make your story positive that will help other people to seek care, to seek help, and rather than hiding? Because when you're not hiding, and I think Ashley had made that very clear, when you're, we want to be able to save lives. We want to be able to have less people being infected. And so this is why it's so important to use the opportunity, not in a negative way, but in a positive way. And I know that from the field, some of the colleagues who are going to be speaking, and Lisa right now, are people that I actually always admire in terms of the Caribbean voices, about their experience, about why the relevance of putting mental health on the agenda, but that is coming not from the voice of the professional, but for the voice of people who know firsthand what it's like to being discriminated, what it's like to being suffering from any other mental illness. So I think this is an opportunity to look at that. So just like they're doing with the heroes in terms of celebrating them, I'm sure we can also help people to be comfortable in terms of their experiences, how much they want to be able to put out there, and how that can be packaged in a way that helps others to validate them, to decrease the stigma.
Thank you. I think this is probably where the discussion will continue after or from the field reporters, because if you look in the chat box, you see there's a little hesitancy. I don't think people think that it's necessarily a bad thing to name the areas, but I think we'll get to that. So I'm going to go into from the field now, because we still have a little time for discussion after. So I'm going to ask Alison Leacock, Dr. Alison Leacock, Chairman of the Barbados Broadcasting Authority, to talk to us about the examples from HIV and also her perspectives on COVID-19 and mental health. Dr. Leacock. Muted. You have to unmute, please.
Thank you, Lisa.
No problem.
I'm sharing my screen and I'm trying to minimize the breeze, but it is hot. So I'll just make sure that
We're hearing you much better now.
Good.
Yes. I'm not seeing the screen as yet, but it's coming. Yes.
Yes, it's coming. Okay, so I'm basically going to draw the similarities between the two. I've worked with the Live Up campaign for 12 years, and there are a number of similarities. As soon as COVID-19 struck, I remember thinking to myself, this is HIV all over again, with one big distinction, and that is that, of course, HIV is very much shrouded in the sexual taboo that we have in the Caribbean. Lisa, one of our Live Up media trainees. She's among over 2,000 who we trained in this area. And there were a number of communication challenges that I feel, again, mirror what we're experiencing now with COVID-19. People are aware of it, but now that some of our countries are beginning to reopen, we're noticing that they're not acting as though they know the impact. There is that. They don't see themselves at risk. That again, because of the original narrative about COVID-19 affecting the people over a certain age, I think there's still that misconception, even though recent data has proven otherwise. The stigma is real. I don't think it has quite the same implications, but because of it, the fact that it is infectious, a lot of people are still marking you, as we would say in the region, if you have contracted the disease. The fact that COVID-19 has the reality of people who are asymptomatic, who can transmit the disease, again, there are people with HIV, they don't have a look. COVID-19 doesn't have a look. So again, the similarity. Testing. Apart from the initial difficulties in identifying it and just not being able to walk in and get a COVID-19 test, I think the shame that used to be associated with an assumption that you were negative when you went for an HIV test, I think there is apprehension about the testing for COVID-19 in the event that the result is positive. But I do want to insert here that the media played a critical role in testing for HIV and can do so again with COVID-19, because we had a scenario with Regional Testing Day where we started out with 6 countries and it was a tripartite relationship. It was government, opposition, we had prime ministers and opposition leaders coming together. We included civil society with many of the key populations. And then we also had the remarkable commitment of Scotiabank as a corporate socially responsible partner. And we began with Scotiabanks being the testing sites. And these were things that allowed us to normalize testing for HIV. And I imagine that as COVID-19 remains with us, that is an approach or a model that could be adequately adapted. Issues of trust in negotiating relationships amidst COVID-19, these are real. If you have a partner that is abroad and is returning, there's apprehension if you are yourself vulnerable. And then positioning COVID-19 among the myriad social and health issues that as a region we are confronting. One other thing to worry about. So these were the communication challenges that I found mirrored what we had with HIV. The major misconceptions, it can't happen to me, and it only happens to other people. And that's one of the really huge issues that we will have to continue to confront. This is a lot. I'm not going to go through all of these, but there are some strategies that work. They mirror some of the points that were made by Jenny, Sue, and Ashley about what works. And so based on our experience, and certainly the data from our HIV work in social media and our media partnerships for HIV, we found that the fear didn't work. We found that the negativity didn't work. And so the empowering positive message that we deliberately used in the Live Up campaign did work. and it allowed people to share their stories without fear, ensuring, of course, that we had informed consent, which is crucial for all media to be sensitive to that fact and to the reality that the person who has agreed to share their story may change their mind midway, and they have that right. So making all of the stories about COVID-19 personal will certainly transmit it from being a public health issue that is out there to it could happen to me, and it is a person that it helps to normalize it. And really, we can also get people to realize there is something I can do about it. I can determine that I will wear my mask and I will continue to observe all of the hygiene protocols. We don't use humor a lot, but humor does have a way of connecting with people. It eases some of the tension and the fear. And we found that well managed and orchestrated with the person who is, of course, the comic being well trained and briefed in advance, it does make a difference. The stats are out there for people to use. And as I said, we can ensure that we're not preachy, and that we certainly use peer impact. Youth to youth always works better than us preaching at young people, and targeting vulnerable populations, using all of our platforms creatively. Those were the techniques that worked very effectively for us, and there's no reason, they're proven, and I think they can be adapted. I wanted to share this clip with you because it comes from a campaign that I did with PAHO in 2017 for Mental Health, World Health Day. And I've chosen this one because it is a journalist from our region who was had the courage to tell her story. And it is a poignant way of showing how, as media, we can become unwitting advocates, or we can be deliberately advocates in sharing information to help others. So I'll play this and hope that everything works as it did earlier. We may not know all of it. Uh-oh.
Is the volume up on the browser, YouTube?
We're not hearing it right now. Do you want to check and see if the volume is up? Or maybe take out your headphones and see if that's what's causing it.
Sorry, you're not hearing her?
No. Try taking out your headphones.
Oh, you weren't?
We weren't hearing you.
Yeah, maybe. Okay. You were not hearing her, or you were not
hearing me? No, we did not
me?
hear her. We didn't hear her. We were hearing you fine.
Okay. Let me change the setting on my headphones, because that is often the challenge with the AirPods. They have to come out. Although I had them in today. Anyway.
Murphy. Murphy must show his head.
Let me try again, and let me know if you're hearing this time.
Hi, I'm Suzanne Mills. I'm a writer and a journalist, and I live in Dingo Martin, Trinidad and Tobago. I think the best way for me to describe depression is to read to you from a poem I wrote in September 2015. Bleeding nail scratch stone, scroll moss and brick, 1 inch up, 10 feet down the water well, itsy bitsy spider, inseed wincing me, letting go, point there's none to holding on, plunging down, feet, torso, neck, head, Welcome death. Life is drowning me. I don't know if I felt suicidal, but what I do know is that I thought that there was absolutely no point to life or living. I reached out to my cousin who also has bipolar like I do. And she said, Suzanne, get a new doctor, you need new meds. The next day, I had a new doctor and she put me on new meds. In about a month's time, I started to feel better, to feel sort of like I used to, at least to feel like a person, for want of a better expression. And I was getting out of bed, not feeling as if the world was going to devour this insy bitsy spider. I wasn't wincing anymore. So I guess what I want to say is there's always hope. There's always a point of it all. There's always a tomorrow. Depression? Let's talk. Let's talk. Let's talk.
So I wanted to share that because of the power of her story. And it comes back to what Sue and Jenny spoke about at the very beginning of the webinar, of amplifying personal stories in an effective way. And this was even more powerful because she is a journalist. So we as journalists can use the platform and be sensitive to the reality of it. So we could do a story impartially and in a detached way, but if we make it personal, it is always more powerful. The second example I wanted to share was the range of scenarios that contribute to mental health and mental health challenges, and how as journalists we can be creative in how we address them. We did workshops combining civil society and members of the media, primarily because we wanted the media to experience what stigma looked like and felt like for the people who were most affected by it. Of course, this was done in the context of HIV, but within that context, there are mental health issues as well. So this PSA was the outcome of a workshop with both media, journalists, as well as key populations. So they gave voice to the voiceless about stigma for them.
I was raped by my uncle when I was 5. I was raped by my spouse.
I was raped by my nanny.
I was raped by a family friend. He said he wanted to correct me.
I was raped by my download manager. I'm HIV positive.
So again, we have a scenario where our temptation is to assume that the media is homogenous, and it isn't, because there are members of the media who are HIV positive. There will be members of the media who contracted COVID-19, but the stigma is real, and they have a very powerful platform to share their story. And as a Caribbean region, we do need to own our stories and feel confident enough to tell our stories. This is one that talks a bit more about the fact that we are more than whatever the condition is. Again, it comes back to Ashley's point about not talking or labeling the person and defining them by the condition of mental health. It's a similar scenario in this one. It's about HIV, but it can be applied as well to COVID-19.
Hey, look at us. Do you remember this day?
Of course I do. Isn't that the day we met?
Yep. And here we are at the family picnic.
And when we went fishing.
Yeah, that wasn't for me. Hey look, you're first Division 1 man of the match.
It meant the world to me that you were there.
It's been 15 years already, and we've come so far.
I'm gonna change it for the world.
Let's capture another memory.
Sure. I'm more than my sexuality. This is who I am.
So again, that is the outcome of another workshop with the media and key populations. So that's something that I wanted to share as an option of the very many can indeed make a difference. The other way is perhaps the more popular way, which is celebrities. But I do want to caution that when we engaged with celebrities to endorse any messaging or to contribute to behavior change, they had to go through very rigorous training before they were a part of the campaign. So I caution about public service announcements in a vacuum, because they need to be part of a far more coordinated, structured communications campaign. You should recognize some of these regional artists. Oops. Oh dear. This one is short, so I do want to share it with you because, again, it includes media and celebrities. Fingers crossed this time. Oops.
Oh, this one doesn't want to play.
That this morning. Okay.
Well, what you can do is probably share the link in the chat.
Yes, I
for this
and this one. Yes, and this one again. We deliberately chose Margaret Gill, who is a poet and a UE tutor, because again of the stigma and the fact that we tend to categorize where people are. So let me just move on to what we can do and what the media can do. We need to ensure and encourage all of our journalists to read and research credible sources for data and indeed for analysis. Having difficult conversations, that's our role as the Fourth Estate, and I think we're not doing it enough. We're taking clips of what ministers and government officials say without probing and getting the backstory. We also have to train our editors, our sub-editors, and our managing editors, because even when we train the journalist, they go back to a newsroom with an editor that has not been sensitized, and the story is buried or not carried. We also need to empower, which was, I was happy to see with from Sue and Jenny, to acknowledge and award quality journalism consistently, so that we encourage a lot of the quality that we want, and it's modeled, and then encourage original programming. That too comes from training and where there's possibility of funding. We had a lot of funding in Live Up, Clinton, Ford, Elton John, Kaiser, but that money is not as prolific as it was then. Social media is there, and of course we can't police it. What we can do is ensure that we have citizens that are DQ, and that digital literacy is more important in being able to discern what we see. The media has the experience and the training to use social media creatively to connect with people who are invisible and anonymous and will not join organizations. That has been our experience, and they gravitate to that because they feel safer initially, and then you can connect them to professionals. I talked about the importance of ensuring that the stories are prominently placed in your A block in the evening news, for example, and not buried or dropped from the newscast. Pursuing the backstory, 70% of our young people are anxious about COVID-19. I haven't seen a lot of stories about that. Why aren't we probing to get some of those stories? Getting into communities, giving voice to the voiceless, and challenging policymakers to make mental health a component, our emotional intelligence, in our training institutions and in the quality of the training we give our journalists, so that they do know, as Ashley presented, and I think Jenny and Sue did as well, how to cover stories with individuals who are impacted by it. 5 key roles for our Caribbean media, just as I wrap up. Media and culture, inextricably linked, similarly with economic development, the political process, changing social roles, and ultimately behavior change. They're well placed for behavior change communication because the media has the capacity, it has the reach, it has the opportunity not just to break silence, to challenge taboos, but also to connect audiences with services and ultimately to build political will. So that's my 2 cents. I'll stop sharing.
Certainly more than 2 cents. Thank you very much, Alison. That was very interesting. And I think we're going to go straight into the other presentation so we have a little time for discussion after. So that was the perspective from HIV, and I was happy to be a part of the Live Up campaign at that time. I'm going to throw now to Kimberly Hibbert. She's from the Jamaica Observer, and she's going to be talking to us about the experience in Jamaica. Kimberly, over to you.
Right, so are you guys seeing my screen?
Not as yet. It takes a minute. So if you've already started to share. Have you started to share your screen?
I have started, but I'm not sure what's happening.
Hold on. Well, maybe tell us a bit about yourself. Let me see if I can get it up on screen if yours is not coming up. I actually have it in front of me. Would you like me to share it for you? Oh, your screen is there. Okay, no, I can see your screen now, but I can see myself. So you have to go to your PowerPoint now. There you go.
Okay.
Go to screen view. Yes.
All right, so for those who may not know who I am, I'm Kimberly Hibbert. I'm a journalist from Jamaica, and I'm really passionate about public health issues, and that really started when I was a student at Carmack from my mere curiosity where mental health care locally was concerned. Following up on that passion, I actually took up a shielding scholarship in 2018, and I pursued a Master of Science degree in Public Health and Health Promotion at Swansea University in the UK. And now I'm back and actually working. And today I'll just be sharing with you some experiences in the field, reporting on COVID-19 and mental health in particular. Right, so experiences with stigma prior to COVID-19. So before COVID-19, stigma as it relates to mental health was and is still very prevalent. Mental health was often labeled as madness, demon possession. Sometimes you might hear people say, you know, your head's not good. And these labels often resulted in fear. So people who had mental health issues were fearful of actually coming forward and saying, you know, this is a situation with me and I want help. Now, another experience locally is that people with mental illnesses are often the subject of online jokes. And you'll see this where something might be happening, as in an individual might be having an episode, and then someone starts filming, it's posted online, then you have TikTok impersonations, either jesting. In addition, these people are often told that they're not resilient, you know, grow some balls or you're too weak. Also, mental health is, apart from being viewed negatively, sometimes we tend to think it's only for certain individuals. So I can be affected by mental health issues. It's not often spoken about or supported. We tend to say it's not sexy enough, so it doesn't get the buy-in from corporate as you would get from the cancers or even HIV at times. And in general, there's a low acceptance of mental health as something that's normal and it affects everyone, 1 in 4 families. But young people that I've observed are becoming more vocal, and we see these in the safe space sessions that happen on Instagram, Facebook Live, whatever platform, Jamaica Mental Health Advocacy Network also has a few sessions. And as we speak about young people being more vocal, I have also had that experience in 2018 when I was studying abroad. I'm not sure what triggered me to actually speak out on Twitter on mental health. And my own experience is having a mother who has bipolar disorder, growing up with the community stigma, family stigma, people sort of pulling away, you're not getting the type of care, going through a series of misdiagnoses. And I found that interview that I did with RGR, Beyond the Headlines with Dion Jackson Miller, sort of people began to realize that this, it can affect anyone at any particular time, and you're really not immune to it. Right, so mental health and COVID-19. So when we heard news of COVID-19 being on our shores, a lot of people started, or myself, let me say, started thinking, how would this impact mental health? And this was based on what was happening globally. So you saw the measures being implemented on the global scene, but this was fresh on our shores. So we were not quite there yet in terms of the lockdowns and so forth. So two questions that I sort of started asking was, how great would the impact on the psychological health of our people be? And I also started wondering, could we see an increase in suicides? And this was based off what was happening globally. Now, when I contacted the experts, the response I got was that, in terms of the psychological impact, you could see either a cognitive or an emotional impact. And this cognitive meaning, poor memory, judgment, or emotional, you could see an increase in moodiness, short tempers, or depression. Where suicide was concerned, though, they said it's not far-fetched, but culturally it's not the norm. So they said, what we should really be promoting is self-efficacy and emotional intelligence. And, they said, Jamaicans are resilient people, and it's not our go-to thing to necessarily take our own lives. But many were still not convinced that mental health issues will really be a problem until it really hit home. And by hit home, I mean, you saw the first few cases, the community quarantines, the rising cases, the curfews, the parish lockdown, the workplace closures, gym closures, stigma against healthcare workers, some Chinese nationals. So anxiety was really at its peak as protective measures were jeopardizing jobs and livelihoods. And in terms of the cases, now the threat of being infected was really high. So people were worrying about their various vulnerabilities. You were seeing young people being infected, they were dying, and this is globally. And then you saw the profile of those dying locally. So the elderly, those with underlying health conditions, and NCDs are on the rise in the Caribbean. Jamaica is no exception. So people started thinking about those things for those who are hypertensive, diabetic, those with the cancer, so forth. And then you had the death of a 4-year-old, and that sort of, had people thinking. And continuing on, it hitting home. Recreational activities were closed. Then we had the forced quarantines, job losses, layoffs, stock market crashing, delayed grief, funerals. So, culturally we were used to the big gatherings, and you have what we call the setup or the 9 nights. Those things are no longer happening. So you're reduced to 15 people at one point. Now it's 50 gathering in a church to bury somebody, the burial ground. All those numbers had to go down. We had the social or physical distancing, panic buying, right? And then to sort of go back on this issue, there were also concerns about domestic violence increasing, right? So we know domestic violence can have implication on one's psychological health. And I think the key lobbyists where this is concerned locally had said that the calls for rescue where domestic violence was concerned had dwindled. And but it wasn't anything to rejoice about, right? Because now they were thinking, okay, these people are locked up with their abusers. What's really happening? You're not hearing from them. So they said, after we sort of move out of this lockdown period, we could begin anticipating that the reports where this is concerned would start increasing. But in the midst of all the worry and the anxiety and the fear, interestingly, a safe space was created, and this was online. And one of the experts actually revealed this. So there was more take up of online classes. We had the hotlines and the helplines developed by the Ministry of Health. Calls for these issues to be addressed were increasing, and this was from influencers online, corporate, and so forth. So we had psychiatrists and psychologists, contributing articles regarding coping through COVID-19. Now, where the contribution of articles are concerned, this was always the case in terms of psychologists or psychiatrists writing to different media houses to get their articles published. However, whether our consumers really wanted to read about mental health issue, that's really debatable and sort of still, up in the air. But now, anecdotally speaking, interest in these articles have sort of increased. So and this is really because everyone was now feeling the pressure and could identify with the understanding what it really meant to feel stressed, to feel anxious, to feel like you're sort of at the end of your rope. Now, so people became more vocal on Twitter, Instagram live chats. People began talking more in their homes and to family members. Participation in self-help activities increased, and we also saw articles where advice was given on how to cope, certain mindful exercises that could be done, how you could actually get the help you needed. In addition, an informal online poll was done by one of our psychiatrists, Dr. Wendell Abel, and he said that it actually showed that people were finding their own ways to cope and sort of integrating or networking with each other on online platforms. So responses to mental health issues now were becoming normalized. And these are some examples of our online platforms in how people responded. So I'm not sure if you're seeing my pointer, but here you see a session says building resilience in the middle, Safe Space Jamaica. And the first one is by the Jamaica Mental Health Advocacy Network. The middle one, Safe Space Jamaica, having a coping through COVID-19 session. The other one, COVID Conversations, which was led by our Minister of Health, Dr. Christopher Tufton. Here we have Corporate Jamaica, Jamaica National, having their online chats, and this one had Professor Wendell Abel and Tracy Ann Goodsmore. In the middle, we have another influencer, Patrice White, and Associate Clinical Psychologist Kamala McQuinney, speaking on managing mental health during COVID-19. Here we have a story where student nurses actually detail some of the struggles they had amidst COVID-19. In addition, we had the banks giving their own tips because, of course, if your investments or your stocks or so forth have crashed, you can imagine how people might have felt where their finances are concerned. And here we have Sagicor giving just a tip where depression is concerned. And this is a story that I wrote regarding COVID-19 providing openness to discuss mental health issues. So, in the midst of the negativity around it and so forth, it actually provided that space where people could be accepting of mental health issues and openly talk about it, which over time would help to sort of reduce the stigma. Now, but in the midst of all that, a recurring decimal from our experts is that the promotion of self-efficacy was sort of still needed. And for those who might be wondering, self-efficacy is really the confidence in the ability to exert control over one's own motivation, behavior, and social environment. So how do we empower people to be fearless, to feel safe, seek help through our reporting, or broadcast, or program, etc.? Now, just some tips in terms of positive reinforcement where mental health is concerned. As reporters, we should always aim to situate reporting on mental health. So don't speak about it as an abstract thing. And I think Alison touched on that in her presentation, where you're trying to get the real experiences of individuals so people can identify with the situation. Of course, you get your expert comments, and this is important. Again, Alison touched on it, where sometimes we see something happening, persons on the ground might just jump up and be like, oh, he is schizophrenic or he has bipolar disorder, and we don't check, how do these people know that this is the situation, right? Talk about the issues. Speak about the prevalence, speak about the stigma. Talk about it so people know that these things are real, these issues are real, and they need to be addressed. Have your human interest stories. So again, person as opposed to illness in terms of the focus. Be mindful of sensationalism as well. Your language, your images, and when I say images, you're trying not to. When you take a picture that is showing somebody who's sad and depressive, it sort of reinforces that stigma that, okay, if I'm having a low mood or so forth, it means that this is how I might always be, or it sort of associates sadness right throughout mental health issues. And these are people who live normal lives, right? And as Alison said, it really doesn't have a face. Be mindful of negative reinforcement of stereotypes, details, and I think one of our earlier presenters from PAHO had mentioned, certainly not going into too much details where suicide is concerned, as you can have copycat behavior, as in people might just relive or try to play out what you have described. And also, people must feel safe sharing their stories with you, right? And that's it. Thank you.
Thank you very much, Kimberly. That was great. And you're getting lots of comments in the chat. And congratulations for your work. We hope one day you'll be an editor and you'll be helping to shape stories taking in these considerations as well. So we're going to move now from Jamaica to Guyana. And I'm now going to ask Tamika Garnett. She works with a colleague, Svetlana Marshall, on their presentation from the Guyana Chronicle. Over to you, Tamika.
Hi, good morning, everybody. I'm trying to share my screen, so just bear with me a bit. Let's see if I'm getting it. Okay.
Okay, it's coming.
Okay, is it up?
Yes,
I know
you
what
can
I
go ahead.
tell if you guys are seeing it.
Yes, we can see.
Okay, I'm going to be talking about COVID-19 and how we reported on the stigma and discrimination in Guyana. For me personally, I think in Guyana we had relatively responsible reporting on stigma and discrimination in the media, because as soon as you would see if an issue of stigma came up, we would turn it around and try to bring it over in a positive light, as Dr. Claudia had mentioned earlier about putting it over in a positive light. The areas where we saw discrimination occur, or where we had potential of it occurring, was mainly with the healthcare workers, as expected, and with persons being tested or suspected of having the virus. And we also had some potential for discrimination with the foreign nationals. And I say potential because for me, I think we didn't see a lot of stigma and discrimination in that area. And I'm going to expand on that a little bit more afterwards. I'm going to talk firstly about the healthcare workers. Now, we had our first case on March 11th. And shortly as the cases started to increase, the first group of persons that were discriminated against or stigmatized were the healthcare workers. It happened really fast. as we were coming towards this first month of recording the COVID-19 cases, then the story started to break of what the healthcare providers were going through. I have here an example of a story that was in the Guyana Chronicle on the 28th of March, where one nurse spoke about an experience they were having. They were having particularly hard experiences getting public transportation, which was really affecting them because a lot of the nurses sometimes work as late, very late into the evening, and they did not have their own transportation. So to be on the road that late and then having issues with transportation, we already see the health system is overloaded with this new disease we're dealing with, and they're already dealing with increased hours and all manner of things, and then now they're finding that they have issues with catching something as simple as catching transportation, making purchases in store. I don't know if you guys can see the example, the testimonials that I put up. I'm going to read one from a nurse, Bob. My first experience that I had was about a day or two after the news broke that the patient that died. I was going home from work and I got into a bus on the 404 bus park. And as soon as I went into the bus, they had people inside of the bus that had on the face mask and everything like that. And as soon as I got into the bus, I was sitting at the front, and it was this middle-aged lady asked, why you pick up this nurse? And I was like, why the driver can't pick me up? In the second testimonial, this is another story on the 5th of May. When the first case was announced, I worked the 1 to 9 p.m. So this is a nurse that was working late shift. And I was going home, we stopped the bus, and the bus refused to pick us up. The driver said having us in the bus would prevent him from getting other passengers. So those are two examples, and you also had examples of the nurses being stopped from making purchases. It was particularly if they were in their uniform. And it had to do a lot with the fear that was created instantly after we had our first case of the virus. Persons obviously wanted to protect themselves from the virus, but because they didn't have the information, they just reacted with stigmatization, like anything. They don't want nurses because they think, okay, the nurses are in the hospital. They don't even know what department the nurses work in, and they just don't want the nurses in the hospital. And shortly after we had the situation with the healthcare, discrimination against the healthcare workers, as I said, what we did with that, we had a lot of positive stories about the healthcare workers. A lot of the media houses started doing stories about what they were going through, the challenges they were facing, and we started, celebrating them. Like one of the panelists mentioned earlier, we spoke positively about them, what they were going through, and we saw a lot of actually citizens responding as well. We had one case of a citizen that at night they would go to the hospital, one particular hospital, and they would pick up nurses and transport them home free of cost. We had other cases where a lot of private businesses started donating to the healthcare workers. We had the telecommunication company created a plan for healthcare workers in terms of cell phones. And some other companies were giving away hampers. You saw a lot of love for our healthcare workers after the story started to break of what they were going through. So then things shifted as the cases increased among the citizens. It shifted to the citizens themselves with the discrimination. Now, because of the contact tracing, I don't think the healthcare workers may have gone about it in the best of way at times, because there's one particular situation that really stood out for me. It wasn't something that was reported in the media, but it was something that was on social media, where some healthcare workers turned up at the home of someone. It looked like it was a case of contact tracing, and they were trying to find somebody that may have been in contact with someone that tested positive for the virus. And the persons at the home, they didn't even want to listen to what the healthcare workers had to say. They just instantly tore off. They took out their own phone and started videoing it, but they behaved atrocious. They were threatening the healthcare workers. They were saying they didn't want them in the yard. They were saying the person they're looking for doesn't live there. And I think that was an illustration of the severity of the fear that persons had of being associated with the virus. And I have two testimonials here from one story that was in the Gyno Chronicle as well, where a person was suspected, a family member that they had tested positive for the virus. So they were suspected of possibly being positive first. So they had to be tested. And even as they awaited the results, the discrimination and the stigma started. In one case, if you look on the left, a popular shopkeeper at Kumaka, this is in one of our interior regions, fired two of his workers because they were related to persons who worked with a woman who tested positive for COVID-19. The owner of a Chinese supermarket also fired a woman who's related to another woman who works with the woman. So you're seeing it's not even just persons who may have been in contact with the person, with the positive person, but any person they were in contact with now also are even getting stigmatized because of it. This other person on the right side, you see, Wong said after persons found out that she and her relative were tested for the coronavirus, she noticed that taxi drivers at Mabaruma were not willing to carry out any favor for the family, including dropping fruits to their home. She said that on Sunday she went down to the pharmacy a few doors from where she lives, and several boys who were on the roadway began throwing remarks at her about the coronavirus. Naturally, when there's stigma and discrimination, it leads to fear, which actually doesn't help the virus, because it causes persons to not want to come forward. If I feel I may have the virus, I will not come forward because how am I going to be treated? And it's a case of you do have the virus and you're not coming forward to get the help that you need to get tested, to get treated. You're going to be spreading it, just being there, spreading it all the time and not getting treatment for it. Or you might even get treatment until it's really late and you might end up dying from it. So we, in one story that's on the 23rd of April, it was in Newsroom, the Minister of Health mentioned that we continue to have the challenge with underreporting from persons who have been in contact with a COVID-19 case, mainly due to the associated stigma. So there was a huge stigma and persons started not wanting to come forward. In some ways, persons tried to make a joke out of it. We didn't take it seriously too much, I think, initially. We'd make a lot of jokes. If somebody coughed, you'd be like, okay, I don't want you around me. But we're not thinking of what persons who actually test positive or who might be thinking they need to get tested, how they feel about how all of this was being portrayed. And then I have on here another case of a family that were tested. This family as well tested negative. But even after their negative results came out, the stigma continued for them. I have some quotes here. They're treating us like total garbage. If they see us walking on the road, they throw their slangs and say all sorts of hurtful things, implying we have the disease. So we didn't have a positive outlook at COVID-19, even though we had responsible reporting. I think that did help to start changing it a bit. And I don't think we have the fear now that we did when the virus initially came out and everyone was so fearful and everyone was afraid, and we started seeing the deaths climbing and persons didn't want to, if they have it, they didn't want to go and get tested. There's another article that came out, this was Stabroek News on the 24th of May, where a regional official from the area where the family that tested negative but were being discriminated, they were calling for the family to get counseling and help with whatever struggles they were going through, how the community was behaving and treating them. Now, I think the least stigma or discrimination we saw for foreign nationals. I was really happy with that. The thing is, Guyana has seen an influx of foreign nationals for over the past few years, we've seen, especially from Venezuela, because the situation that's going on over there. We saw from Brazil and Cuba. The Cubans started coming here because of the embassy situation. And but even since they've been coming, we generally don't have much cases of xenophobia in Guyana. I think it has a lot to do with our multi-ethnic, multi-religious makeup in Guyana. We're diverse and very accepting of people. They blended in easily and they were like a part of the landscape. And I think this flowed over into the situation with COVID-19. We didn't have a lot of negative feelings in Guyana about foreign nationals. In any case of widespread discrimination or victimization, if we did see a foreign national do something negative, you would see that person being judged on an individual case. Like there were some Venezuelans that escaped a quarantine facility. It is for all of our benefit that they stay if they're suspected of having coronavirus. But they escaped because I think they were trying to go to another country. But what we saw is that even if persons had negative feelings about what they did, they said those Venezuelans that escaped, you wouldn't hear them say something like all Venezuelans are spreading the virus in Guyana, or Brazilians are spreading the virus in Guyana. We didn't see any of that, even though we did have reporting of them escaping from facilities. We had a picture with, there's a picture there with for women, Venezuelan women that were handcuffed after they escaped the facility, and there were some difficulties with the Minister of Health did come out and speak on that and say what was going on. Later down, we had a call for the closure of the borders with the countries, because as the cases were rising in Brazil, persons did have concern in the part of Guyana that is closest to the Brazilian border. But even then, you didn't see it being any sort of a xenophobic type of fear. It was more a fear of, okay, Brazil has a lot of cases. We need to protect ourselves. We had a Brazilian that was in the Rupununi escape and went over back. We had some other Brazilians that were passing in. There was generally a feeling that a lot of Brazilians were bringing it into the Rupununi. But still, you did not see that feeling that all Brazilians are spreading the virus or anything of that sort. You just say, okay, those Brazilians are doing something bad and we need to deal with them. Or we're not saying, okay, all Brazilian, anywhere you see them, they're bad. So I think that was very good. And how we did report on it too, we encouraged that. But also the general atmosphere of how Guyanese are and how accepting we are, that kind of created an atmosphere for it to be not have that stigmatization for the foreign nationals. There was a case with the Chinese. I didn't see any reporting of this in the media, but I did come across it in personal encounters where they were like, okay, the Chinese are responsible for the virus. Again, that didn't take any sort of a big widespread kind of get any root or anything. It was just some isolated cases or anything. Sometimes it was a joke, but you didn't see any sort of widespread attack against Chinese, like, okay, they're responsible for the virus, we don't want anything to do with them. We saw none of that. Everybody was pretty accepting when it came to foreign nationals. So it was merely discrimination against our healthcare providers and discrimination against persons who were suspected to have the case. And I do think how we reported on it, bringing those discrimination people were facing, the stigma they were facing. And we even had a lot of stories about mental health. I didn't touch on that in my presentation, but we did have a lot of stories giving persons ideas of what they could do at home, talking about some of the things persons were going through at home or dealing with in terms of being stuck at home all the time or having their normal life contracted so much. And there was a lot of videos and talk about it. I don't think we had anything big, but I think we did have very, very responsible, in my opinion, very responsible reporting on the virus in Guyana. Thank you very much.
Thank you very much, Tamika, for sharing with us the Guyanese experience. I love being in a regional room with all of the different accents and hearing from the different perspectives. So I am going to go straight because we're close to wrapping up time. There were two questions. I see Philip Swan, and before Indira Clark, because I have Philip right in front of me on the screen, I'm going to allow Philip to talk. So Philip, please go ahead and ask your question of any of the presenters. And Tamika, you can stop sharing if you'd like. Thank you. You can unmute and go, Philip. Go ahead. Okay, let me go to Indira. Are you ready, Philip? Okay, Indira, I've also allowed you. If you're ready to go, you can ask your question.
I don't have a question, sorry.
Oh, your hand was up. Okay.
My apologies.
No problem, no problem. Indira, do you have a question or were you just waving at us as well? Indira? Okay, I don't see any other questions in the chat box. Maybe, I know what definitely came out for me is, it seems to me like it's fear-driven. Certainly, hello?
I want to just congratulate, if it's okay with you, Lisa, just a quick congratulations to our presenters. It was fabulous. I think coming from me as a mental health provider, I could not be so happier, you guys. I've been doing so many webinars, so these webinars are so important for us. This is definitely one of those that will definitely make my day for today too. Alison, fantastic job. It's great work that you're doing. I think we have a lot to learn from the, the campaign, the HIV campaign. I always remember even the jingles, they were always fun. So help people to keep this talking about this. So just congratulations to Tamika. We had another from Jamaica.
Kimberly, yes.
Really fabulous work that you're doing with the professional, with Dr. Wright and Wendell. Those are fabulous professionals to work with, and that was the recommendation from Jenny and Sue to make sure that you go to the source of your information, that are people professional, reliable, and this is what you guys have been doing. So I could not be any happier to see that, hopefully we continue working with you. I'm so glad that CDB had also, this is the work that Elisa has been doing with CDB, to make sure that we continue collaborating, and as I said, the role of the media is fabulous. So I know Ashley may want to add something to that, but from PAHO perspective and from my perspective, it was fabulous. So thank you for being with us.
Thank you, Dr. Claudine. We have someone who is asking us again, and I think they really want clarity on this. Just to be clear, are we saying that announcing the various COVID-19 hotspots is encouraging stigmatism? They want to be clear on this, and it's a delicate balance here. Anyone can take this.
Sure. Shall I jump in? So I guess what we were emphasizing is announcing individuals that have COVID-19 in certain areas without their explicit permission. We are saying no, absolutely not. We need to encourage these real stories, and by sort of naming and shaming people, that just contributes to stigma. Now, as we mentioned earlier, the ministries of health are generally announcing those hotspots. It is a delicate balance because we don't want certain, localities and certain neighborhoods to be associated with, high rates of COVID-19, et cetera, So I think we really need to look at why we're doing it, and to use our judgment. When it comes to sharing personal stories and giving that information as part of the personal story, that's what we're suggesting that reporters really avoid. Over.
Thank you, Ashley. Anyone else wanting to comment on that? No? Okay, I don't see any other questions in the chat. Alison, were you saying something?
No, just that I commented already on it, so
okay.
I won't.
Yes. Okay, I don't see any other questions. Oh wait, there's one more. Okay, just saying thank you for the presentations and the opportunity. People are very happy for these trainings. Just to say that we do intend to have at least 2 other trainings on mental health. I believe we told you before, but just to remind you, we'll be talking about domestic violence in the next one. It is an issue, especially during COVID-19 and the pandemic with the added stressors. That is definitely happening, and we will be doing a session to talk about that. And then we'll also be talking about the economic impact of the COVID-19 pandemic and that's the implications for mental health. I just want to remind you that we will be relaunching the campaign Stronger Together on July 20th. So you'll hear more about that from us. And that's a campaign which talks about psychosocial support and helping persons, because in the Caribbean, we're dealing with COVID-19, but we're also in the hurricane season. And that is also something that is, I don't know about you, but from June 1st, I get a little anxious for sure. So that's something that we will be talking about really soon. So right now, I just want to thank everyone. Are there any last comments from the panelists as we wrap this up? Are all hearts clear? Sue, go ahead.
I just wanted to say thank you from Jenny and I for allowing us to be part of this amazing session. Honestly, you know, I've done work on mental health stigma for about 25 years at Mind, and gosh, what an amazing set of presenters and expertise across, you know, mental health, HIV, COVID-19. But there's so many similarities in effective approaches in working with the media and journalists. You know, Kimberly, Alison, Ashley, you know, Claudina, what you've said, you know, I think there's a lot of shared learning here and a lot of shared approaches. I'm really keen that this can be shared more widely, you know, across PAHO, but across globally, with people that want to work with the media to improve reporting and therefore start to reduce the impact of stigma and discrimination. So I wonder if this has been recorded, if we can then share this with others. I definitely think our partners in Africa and India would be really keen to hear from journalists, from campaigners, from health professionals, everybody in this room. I think this kind of resource would be really helpful to many other parts of the world. But just thank you. It's been an absolute honour and inspiring to see all this great work, isn't it, Jenny?
Thank you. Thank you very much. We're really happy that you were part of the presentations today as well. And yes, we did record it. I hope I said that earlier. We will be sharing it on our PAHO TV YouTube channel, and everyone who's here will also have the opportunity to get your own recording. So I know sometimes some of the journalists would like to do a story based on what happened here today. Feel free, we'd be happy for you to share what we've said today. So we will be sending you a link with the recording, and it will also be on our PAHO TV YouTube channel. So I just want to say thank you to everyone else who helped behind the scenes. Dr. Prieto, who wasn't here today, she had to be drawn away due to something happening at home, an emergency. So we're sorry she couldn't be here, but I will update her as soon as we come off. Thank you to Ashley, Claudina, of course, to our behind the scenes, the only gentleman in the room who you couldn't see, David Spitz, for helping us with all of this, to the CDB, to CBU, to everyone who made this possible. Thank you so much for joining us again, and all of the presenters as well. Until next time, thanks for joining, and see you in the next presentation. Thank you and have a great day.
Bye.
Thank you. Bye-bye.
Bye.
Bye.